Hello everyone, good afternoon to Prof. Salim and my fellow classmates. So today our group from Group 3 will be presenting on the safe medication quality care, a TQM approach to eliminating errors and enhance patient safety at Hospital Sultan Baya. So we have chosen Hospital Sultan Baya as our institution, and previously our group already presented on the hospital background, the data on the medication error, the guideline that related to medication error in our hospital and also in Malaysia setting, and also our reporting system. So today we will recap a bit on the problem and also moving forward with the proposed solution. So for today's presentation, our group decided to apply a few of the TQM framework and also tools that already been taught to us. So start with our Six Sigma and that contain the define, measures, analyze, improve, and also control. So to start off with define, this is our problem statement, which is the medication error at hospitals Tanah Bahia have been increasing over the recent years and posing a serious threat to patient safety. And also it leads to prolonged hospital stay. And then moving on to the next component of Six Sigma, which is the measures already presented also previously, which is, oops, didn't move. Okay, which is include all these six components, which are the average intervention time taken on medication error, the percentage of medication orders verified via barcode scanning, the percentage of medication reconciliation performed at admission and also discharge, rate of medication error reported medication error reporting system, which is the MERS, and also rate of preventable adverse drug reaction. So moving on the next component of Six Sigma, which is the analyze. So from our analysis, we decided to use the Ishikawa chart of the fishbone, and we highlighted these eight root causes that leads to medication error, which highlighted in red and further discussed in our next slide. So in the improve, which is the proposed solution of our groups, first we will start off with this prioritization matrix. We include all the eight root causes, which we will address everything. But we highlight all these three components, which are the most important one, which is the complex unclear medication workflows, insufficient training on error prevention, and also look alike sound alike drug packaging. Why we chose so? Because it has a high impact but process of redesign needed, easier to implement with restructured programs, and also relatively easier with procurement and labeling policies. So moving on the first steps of the on the first root cause, which is the look alike sound alike drug packaging, which we try to adopt the PDSA cycle. So in this PDSA cycle, we can see that it is important to acknowledge that the look alike sound alike drug packaging is a very severe problem in our hospital. It is a common error often occur due to similarities in drug names or packaging, and our goal is straightforward. We aim to reduce the incident linked to those errors by introducing system-based safeguards. And our steps is by conduct an audit. We will begin with identifying the top 5 Lassa drug pairs contributing to the incidents. And this is a crucial step which enable us to target our intervention more effectively. And implementation differentiation strategies will include the applied strategies like Tolman lettering to visualize the differentiated of the drug and also lessen the confusion. How we will monitor is by compare the number of Lassa incidents before and after the intervention and also collect feedback from the staff. And lastly, how we will act upon it is standardize the safe labeling practices hospital-wide and also develop and distribute a high-risk Lassa list through the emails. So with that, I pass to my colleague, which is Dr. Mohamad Asyraf. Thank you.
Okay, thank you very much, Dr. Izzaz. I'll continue with the second root cause to be addressed, which is complex and unclear medication workflow. So under the plan, the problem is clear here, where the nurses have reported confusion, which can lead to medication error. And our objective is pretty straightforward, where we aim to simplify these workflows by introducing a visual medication round checklist. So next, let's look at the do component. We will start by trialing this checklist in one high volume ward, like orthopedics. And then we will observe the nurse compliance and also monitor error frequency closely. To proceed, then after the implementation, we will compare the medication error logs before and after the checklist is introduced. Additionally, we will also conduct a staff survey to gauge the perceived clarity and usability of the checklist. And then on the act component, once we gather feedback, we will revisit the checklist accordingly and aim for the department-wide implementation. On the third root cause, it is under insufficient training and error prevention. Okay. So under the plan, many new staff members are unfamiliar with the essential protocols, which can increase the risk of error. So our objective here is clear: to improve staff knowledge through monthly medication safety drills. How do we plan to achieve this? Is by having run 2-hour case-based workshop that include role play to address common errors. Then we will implement the pre and post-session quizzes to assess learning, allowing us to track reported errors between trained and untrained staff. On the act component, we will plan to include these drills in new staff orientation and tailor them to be department specific to ensure relevance and effectiveness. Next, the fourth root cause will be on ineffective medication reconciliation steps. Here we plan on the problem is to address the discrepancy during patient transfer or discharge. So the objective is to reduce reconciliation related error by 40% within the next 8 weeks. What we're going to do is that we plan to assign a dedicated nurse or pharmacist to complete the reconciliation process using a standard form. This focused approach will help streamline the workflow and ensure accuracy. Next, we will conduct an audit of 30 detailed summaries to identify any reconciliation issues, and this will also allow us to measure the frequency of mismedication and or duplications. And finally, during the act phase, this will involve incorporating our reconciliation form onto the EMR discharge note and training our staff during weekly meetings. On the fifth, root cause, so it will be under poor integration of electronic prescribing system. So let's look at the plan, and the problem here will be fragmented and on delayed communication, which can lead to serious error in prescription. The objective is to improve integration between the pharmacy and the ward and targets a reduction in prescription communication error. How we're going to do that is by implementing the alert system in one pilot ward, for example, the medical ward. We will also train the doctors and pharmacists on the new study protocol. Next, we will closely monitor the prescribing delays, which includes pharmacist clarification and override log. Additionally, we will also conduct interview to gather essential usability feedback from our staff. On the act component, if we see a drop in error rates, we will scale the system to more wards, also refining our alert filters, which help minimize alert fatigue, which is a common issue in the system. On the next course will be human fatigue, stress, and also miscommunication. Again, with the PDSA cycle. First, we will identify the problem, which is errors during end of shift due to fatigue. Our objective is to pilot a protected 10 minutes buffer for handovers. So this small change can have a big impact on clarity and communication during this critical transition. How do we plan to implement? As mentioned, we will introduce a 10-minute early sign-off policy for proper handover. And additionally, we will set up a caffeine-free hydration and snack station during evening shift to help support our team's well-being. So in the study phase, we will closely monitor medication errors during evening shift and conduct staff surveys to gauge the quality of handover and level of fatigue experience. And finally, as we move to the act phase, we aim to institutionalize this new policy and even propose a roster shuffle for better shift coverage to ensure our staff are well supported. On the 7 root cause to be addressed, underreporting of errors due to a blame culture. First, under the plan component, the problem here is that staff often fear punishment, which inhibits their willingness to report near misses. So our objective is to increase near miss reporting by 50% in just 2 months. How are we going to achieve this? By launching a safe to speak campaign with anonymous reporting. We will also engage our leadership to consistently highlight a non-punitive culture during daily briefing. In our study phase, we will monitor the volume of error reports on a monthly basis. And additionally, we will conduct a survey to assess staff perception of our safety culture. And finally, in the act phase, we will share anonymized lessons learned on the monthly basis and integrate recognition for those who report error into performance appraisal. So this will reinforce positive behavior and encourage a culture of safety. I'll pass on to my colleague to continue on the last root cause to be addressed. Thank you.
Okay, thank you very much, Dr. Asyraf. To continue, let's shift our focus to the issues of patient staffing and high workload. We face a significant challenge with high ratio of patient to nurses during medication round. Our objective here is to justify the need for temporary relief staff, particularly during peak hours. To address this, we plan to try adding one float nurses during the busiest time, particularly from 7 a.m. to 9 a.m. and again from 5 p.m. to 7 p.m., probably by the deployment system approach. So this data will allow us to propose a data-driven justification from expanding our staff. We might also explore task shifting strategies to elevate some non-clinical responsibilities from our nursing staff. So by implementing these changes, we aim to enhance patient safety and create a more supportive work environment for our nurses. Okay, let's now explore the last component of the DMIIC framework, which is the control. So before we proceed to the measure for each of the root causes, let's discuss what happened when the medication error occurred. We conduct a thorough root cause analysis and to investigate the incidents. This step is crucial because it allows us to identify the underlying issues contributing to the error. Once the RCA is completed, we share the lesson learned with our staff. This transparency is essential for fostering a culture of safety and continuous improvements. Next, we update our SOPs based on the finding. This ensures that we adapt our practice to prevent similar error in the future. Finally, we perform a re-audit to check compliance with new SOPs, monitoring KPIs, providing valuable feedback to our teams about how effective we are implementing these changes. Next. So as we dive into our approach to address root causes, let's focus on the specific control measures we have implemented. However, I will emphasize more on the monitoring and evaluation for each of the specific control measures. On the first root cause, look like and sound alike drug packaging, we are targeting a rate of preventable adverse drug events in inpatient setting to be under 2 per 1,000 per patient days, whereas for outpatient setting, we aim for less than 1 per 1,000 visits in monthly data collection. Responsible team involve pharmacy department, medication safety officers, and as well as quality units. Next is in enhancing our medication workflows. Our goal is achieving at least 95% medication order verified via barcode scanning in quarterly manner. The ward nurse managers and quality team responsible for these indicators. Next, under insufficient training on error prevention, we are targeting a rate of preventable adverse drug events in inpatient setting to be also below 2 per 1,000 patient a day and less than 1 per 1,000 patient visit. So this will monitored quarterly by our HR and nursing education units in preventing adverse events to the patient. Next up, for the ineffective medication reconciliation step, we aim for at least 90% completion during both admission and discharge, which will be responsible by pharmacy department and quality teams. Next, for poor integration of electronic prescribing system, our success will be measured by a 10% yearly reduction in intervention times and also achieving more than 95% error-free electronic orders. The health informatic and IT units will lead this effort, and evaluation done annually, quarterly, respectively. On top of that, to address human fatigue, stress, and miscommunication, the key indicators identified here are: one, 10% drop in medication error intervention times, and second, more than 80% SBAR compliance. This is monitored by our HR units and head of departments accordingly in annually and a quarterly manner. So to complete our presentation, I pass the floor to our colleague. Over to you, Dr. Faris. Thank you.
Thank you, Dr. Firdaus. We'll move on to the next control measures. As we go into the specific control measure addressing the root cause we have identified, let's talk about the under-reporting of errors due to blame culture. It is crucial that we promote an environment where anonymous reporting is encouraged. This not only protects our team members, but also fosters a culture of safety. We'll be implementing safety culture sessions and role modeling from our leadership to support this initiative. The indicators here would be the rate of medication errors, percentage of anonymous or near miss reports, in which the target would be more equal to 15% of near miss reporting. And those who are responsible in this will be the quality and the risk management unit. And lastly, we would need to highlight our goal for the average intervention. And next, we would have a look at the insufficient staffing and the high workload. where the specific control measure here, which has been mentioned earlier, would be the minimum safe staffing policies and the real-time nurse allocation system. The indicator that we will be following on this would be the average intervention time taken on medication errors, and the target would be 10% reduction from previous calendar year. And those who are responsible for this would be the nursing, admin, and also the HR unit. Now, as a summary for all the control measure, firstly, we recognize that reconciliation issues, the reconciliation issue plays a significant role in our medication error. This is why we can implement integrated health information systems combining the bar medication administration, BCMA, and computerized physician order entry. Next, we would have a look at the look-alike, sound-alike drugs. By utilizing tall man lettering, as mentioned earlier, and segregated storage, we can minimize confusion and enhance safety in our medication practices. And also, we would see how in regards to reconciliation issues, there will be a structured pharmacy-led reconciliation at entry and exit, over the discharge and also the admission. And in regards to the blame culture, as we mentioned earlier, we would introduce anonymous misreporting and also a non-penalized culture. In regards to the fatigue and errors, we would rebalance rosters and introduce a no interruption zone, especially during medication distribution. And in terms of lack of learning, we would hold a quarterly review panels and also publish a monthly bulletins. These are some of the images that shows how the process of improvement in regards to medication that shows a sample of the Tolman lettering, which are distributed via email on monthly bulletins. For example, the Viga Batrin and also Vida Gliptin, where the Tolman lettering is on the GABA and the Daglip. And next image will be enforcing the nurse on duty vest while on duty of preparing or delivering medication. This minimizes the interruption and result in reduce in odds of medication error. And thirdly will be the sample of barcode readers for medication prescription. In summary, medication errors at HSB stem from multiple systemic failures, ranging from process complexity to environment distractions and cultural factors. By applying Lean Six Sigma, human factors engineering, and local MOH guidelines, the multi-pronged strategy can be implemented. Key improvements include simplifying workflows, strengthening reconciliation, promoting culture of safety, enhancing training, and leveraging technology. The sustained success will depend on leadership commitment, ongoing monitoring, and integration into HSB operational policies. Together, by focusing on these areas, we can enhance patient safety and improve overall care. These are our references, and these are our group members, Dr. Mohamad Asyraf, Dr. Izzaz Azman, Dr. Firdaus Bin Yusof, and me, myself. This will be our final slide. Thank you for watching, and the floor is open for any questions. Thank you.
Thank you.